Dr. Shekhar Bhojraj, and he will be talking about the how to address the back pain safety in low and middle income countries in primary care settings.
Good afternoon, everybody. Are we at the Spine Foundation qualified to talk on this topic? There are three aspects: back pain management, low income group of underprivileged and the unaffording, and the primary care setting. So I feel that on all these fronts, the Spine Foundation could have something to contribute. The Spine Foundation was founded 25 years ago, and it's presently celebrating the Silver Jubilee. And the basic vision has been setting up a comprehensive spine care program for the unreached and the underserved populations of rural and urban India. Some statistics which I'll quickly go through: more than 70% of India's population lives in the villages. Problems in our region are basically lack of affordable private insurance and self-paid health care. The government health schemes do offer schemes which are free, but they are substandard, and there is a lot of out-of-pocket expense which is there. As you can see, the primary health centers and ambulance services and transportations are on paper there, but not functional. The concept of CHE, which is the catastrophic health expenditure, is very vital in our country. A small illness, especially a spine problem, could get an entire family below the poverty line and drive these families for hazardous outcomes. We have seen all these statistics in the previous slides, and I'm going to. So why work on spine problems? Is it because we are spine surgeons? No. We have seen lots of literature and in the previous paper that it's a global burden of disease and it's fast increasing. Just an example of a tribal girl in the periphery of Maharashtra, the local state, who had to travel almost 460 kilometers to get her spinal injury treated. And that's the health minister getting aware of the situation. The Spine Foundation, since its inception 25 years ago, has specialized in management protocols which are specifically geared for the have-nots, which happens to be the topic of today. The whole aim is to initiate spine care setups in areas where affordable and rationalized spine care is not available to the unreached and underprivileged. Although it's a spine surgeons group, we completely appreciate the need for conservatism, and 8 out of 10 patients we see are treated conservatively with the evidence-based rehab programs. This is done in collaboration with multiple organizations, and one of them is the ASSI, which is representing today. We also have what is called as the Association of Rural Surgeons of India. How do we do it? It's basically a team effort, and it's a group of 40-50 spine surgeons from all over the country with delegation of duties and decentralization. A typical working module consists of conducting camps, local surgeon involvement, assessing the needs of that population. In a particular area, there may be sickle cell, there may be TB. In other areas, it could be mechanical back pain. Identifying local setups where we could start these, small efforts or initiate efforts, and then setting up systems and teams. The success of this venture lies in turning them into turnkey projects for handover eventually. We don't intend to be there forever. So it comes down to empowering the local village health workers, identifying local doctors who are interested and who could cooperate, and of course, developing financial self-sustainable models using available government schemes which are on the rise now. The COVID period did teach us a lot of things, and one very important thing was the telemedicine, because we used to travel almost for a day to reach in interior tribal areas. But with telemedicine, we are doing clinics with the local doctors now and avoiding these long trips. As I mentioned earlier, although most of us are spine surgeons, we value conservatism, which is 80% of the work. Quickly going through some of our work in the rural area. It all started around 20 years ago in Gadchiroli. You must have heard of this place, which is manned by Padma Shri couple, Abhay and Rani Bang. We are going to listen to Dr. Anand Bang, who's their son, today later in the next session. The entire work is done through the health workers. She is Kazubai, who is a village health worker, who basically popularized the program which was acclaimed by WHO on infant mortality. And their work on infant mortality improvement, the rate, was published as a combination of 19 original research articles in Journal of Perinatology published in the US. A few slides about what we did over the last 17-18 years in Gadchiroli. This was the initial phase where we conducted clinics. We stole electricity from lampposts and conducted clinics late in the day. These are the mobile clinics. It was a double-decker approach, mainly the service front, but we also concentrated on the research front and worked on getting some of these details about prevalence, risk factors, and natural history. This is some of the realities where patients have spine problems, the type of work they do, the life they live, carrying weights on the head, bending down, working women, daily wage workers. So group discussions with villagers over the last 2 decades, trying to find out what the real problem was. Also respecting the local remedies like herbal medicines and other branding and other things which were popularized, which were of great use, especially in non-specific low backaches. The key was reaching out, because sitting in a place in an NGO hospital, we did not get a patient coming 35-40 miles from interior. There's such a picture of a tribal lady who was found with a cauda equina lesion in the bed with a small bed sore, who had to be lifted off and brought to the NGO hospital. Things have improved now, and we now have outreach mobile medical units which reach out. As we all know, more than 80% do not need surgery. They just need rehab and conservative care. 15% need some sort of, we just heard in a very good talk just before on the red flags who need investigation. And out of those, maybe 10% need some sort of surgery. A few of them have to be picked up and brought to the metros because they need advanced surgeries with ICU backups and spinal cord monitoring. So this was the pre-online OPD, pre-COVID era, where we used to go and see almost 400-500 patients. Conservative care, which is needed in more than 80%, is provided with interactions and discussion with the village health workers and their training programs. Initial surgical camps, and now we have state-of-art theaters in the periphery. Constrained innovations is the key. And initially, we had very basic radiology setups with drying the X-ray films on trees and things like that. So lessons learned so far from these rural outreach programs was to identify the red flags and avoid unnecessary expenditure. The ongoing research project, which we started in 2010, around 13 years back, has yielded useful data. We don't have time, but there are a series of almost 7 to 8 international publications on the work done in Gadchiroli. Dr. Anand Bang is one of the co-authors, and he's going to talk to us in the post-lunch session. So our dream with the rural area has been to manage rationally, published the guidelines and set up role models in developing countries. Coming to the urban areas, if you visit Mumbai or Calcutta or Delhi for that matter, you will have migration from villages. So there are basically villages inside the metros and the problems are real. This is one of the NGOs we work in central Mumbai. Some of them are actually worse than some of the villages with real needs. And many of this population is uninsured because they are migrant population, the workforce for major work, and they need care. So this is the NGO where we work through the urban health workers. This is one of the peripheral hospitals which we have adopted for last 13 years in Mumbai since 2009, and the foundation is working there. Some of the statistics. These are the patients, some of the village patients, the foundation subsidizes their travel with one relative and we work on them. We have state-of-art theaters here for the poor patients. Complex surgeries are also performed in a small percentage of these patients. Meticulous record keeping. So plan of action is upgrading services at the primary health centers, upgrading and transfer of teaching staff and residents, and developing strong linkages with the peripheral hospitals and teaching hospitals. A final few slides on developing a model for comprehensive spine care. While I was listening to the morning talk on the WHO package, I got some glimpses of something what we have been doing for the last 20 years. Setting up a model of comprehensive care involves identifying the needy and willing areas all over the country, awareness, camps, triage, counseling, surgeries, if at all required, and then finally handover. We have developed what is called as a 5-filter concept, which looked very similar to the WHO package. And filter 1 is a village health worker, ASHA workers and community health workers, and educating them and making them aware of the basic spine problems and making them aware of the red flags. Nowadays, we have also started delivering rehab measures through the health workers by physiotherapy assistants. Filter 2 is the primary health center medical staff unit with doctors and nurses. So these are the training sessions for the village health workers. These are the education of the primary healthcare doctors in the interiors. This is the filter 3. We are going to listen to the talk on marketing. I think in the small places and remote areas, the local newspapers and radio channels are very important to spread the awareness of what we have to offer. These are some of the PHC doctors being addressed. Filter 4 is the established orthopedic setup, which we set up in the place, in the NGO or the local civil hospital. And the 5th filter is the urban hospital or the metro hospital I showed you. So now we are spreading out, and the 3 types of areas where we spread out: the NGOs, the non-profit organization setups. The second is the government, civil and district hospitals who do not have a medical college. And finally, the government medical colleges who have the orthopedic departments and a good rehab team. We normally try and avoid corporate or trust hospitals because there the filtering of the needy and the affordable becomes a challenge. Few examples of where we have been. This is interior Maharashtra, Ambejogai, Akola. The advantage of some of the medical colleges that we can teach the local interested people. So the handover becomes much easy. We can move out and move to a new center. This is one of the colleges in Kolhapur. We just came back 2 weeks ago. Ratnagiri, which is a coastal area in India, again adopting a municipal hospital which did not have any spine, any orthopedic care even, which we did a handholding. So now in the last 25 years, this is the latest center in the middle of Himalayas. That's another area which is very difficult to approach. This is beyond Dehradun, where we have adopted a mission hospital. It's called Vivekananda Mission Hospital. Last 2.5 years, we have been working there. We have taken out taken on ourselves to start 5 new centers out of these 6 in the coming 6 months in Gujarat, Madhya Pradesh, West Bengal, Karnataka, Goa, and Orissa. So lessons learned and future dreams, scaling up the model to as many places as possible. That makes us imperative to hand over the existent ones. We are setting up what is called as a National Center for Comprehensive Spine and Musculoskeletal Care at Gadchiroli. We are in the 4th year, and I think Dr. Anand Bang, who's speaking to us today, will speak about it. Critically evaluating and studying the comparative outcomes, and I was very impressed by the talks on the outcome analysis. We have had big problems in analyzing outcomes, especially in these areas, because a person comes 35 kilometers almost picked up, and once the patient is, last 2 slides, once the patient is better, he disappears in oblivion, and to get an outcome becomes difficult. So we have now special teams to reach out and find out how they have done. So we thank the foundation, thanks all of you, and especially the organizers for giving us this opportunity to introspect, convey, connect, sensitize, and hopefully excite. We invite you to, I have got some literature on the foundation, the journey for last 25 years. If you're interested, please pick it up. We also have some newsletters. And I would like to be a regular member of the such G20 meetings. Thank you.